Thanks, Alan. And I would like to join you in thanking the patients who contributed to this. It's not easy to talk about this sort of problem, particularly in front of a camera. For those of you who've done it and those of you who are here, and I know some of you are here, thank you very much. Alan's talked about the pictures. We've taken out the worst pictures. But I didn't feel it was possible really to talk about this without showing something of the sort of things that men have when they present with penile cancer, perhaps most relevantly, that men are left with after they've been treated for their penile cancer. And my main job, I think, is to to talk to an audience with very varied background. We've got professors of urology in the room, and we've got patients in the room. We've got members of press in the room who probably won't have heard anything about penile cancer. My main role is to take you through a little bit of the clinical basics of it. It's very rare. There are about 600 cases per year in this country, and until a few years ago, most urologists, because they're treated by urologists, would only see 1 or 2 cases per year. But with the IOG reorganisation of cancer services in the UK, about 8 years or so, penile cancer is now centralised into about 8 or 10 units across the UK who see the vast majority of these patients. And that's facilitated this sort of research. This sort of research would never have been possible before that rationalisation of services. One of the features of it is diagnosis is delayed, and that delay, I think, is twofold. Firstly, men are naturally embarrassed about changes to their penis, and they tend to think it'll go away or hope it'll go away before they go and see somebody. And secondly, because it's rare, doctors, particularly GPs, are not entirely familiar with the sort of things they might see on a man's penis, and often there is delay at primary care level before the patients get referred on. When they do get referred on, surgery is currently the mainstay of treatment, and the principle of treatment is that you remove the cancer and you remove as much of the penis as is necessary to ensure that the whole of the cancer has been removed. And as a consequence of that, there will inevitably be functional changes. There are, if you think about the penis in broad terms, a man pees through it, he has sex with it, and he would like to think that it looks okay in terms of his masculinity. And so those 3 areas that are relevant to penile cancer, which actually in terms of the treatment are very poorly and under-researched. Well, it's a disease of elderly men, but not always, and I'll show you one of the pictures you will see that is of a relatively young men. Perhaps 20% of the cases are men under the age of 40. It's very rare in this country, but in other parts of the world, it's one of the commonest cancers. And it's one of the commonest cancers because probably either the consequence of viral infection or of hygiene issues. And it's usually those 2 things that contribute to that. You never see it in men who are circumcised at birth, so it's almost unheard of in the Jewish population. It's very rare in the Muslim population. But in men who keep their foreskin, penile cancer can develop. And the assumption, therefore, is that it's something that gets under the foreskin that causes the cancer. And that might be a viral infection, or it might also be dirt, might be a hygiene issue. All the men in the room will know that they invariably wash their hands after they've been to the loo. But how many of the men in the room wash their hands before they go to the loo? And just think that if you're in a dirty job, whether you're a car mechanic or whether you're working on the road and you've got dirty hands, and I spent some of my time before I did medicine doing a summer job working on a building site. I never washed my hands before I had a pee. And so you are transferring dirt onto your penis whenever you do that, and that hygiene issue is probably a contributory factor. It's commoner in men who smoke, and indeed it is one of those cancers that is related to smoking. This was a young man who was 6 weeks away from getting married. He came to see me with that red lesion on the inner aspect of his foreskin and on the head of the penis, which ultimately proved to be a cancer. And he had to have surgical treatment for that. And that would be one of the earlier presentations that I tend to see. Men often present with a red patch like that, or with a lump, or with an ulcer, or with a little warty growth. And they may present with a foreskin that won't come back, and with a lump underneath it, with a discharge appearing from that. And those are the sort of things that should worry a doctor about that cancer might be there. As I already mentioned, a significant proportion of these cases are delayed. This was one study reported 2 or 3 years that suggested that about 1/3 of the patients had some significant delay between the onset of symptoms and actually getting to the urologist. And that delay was split between the patient being later to the doctor than would otherwise be the case, and also a delay in diagnosis, usually in primary care. To make the diagnosis, you've got to take a biopsy, and when the biopsy is examined in the laboratory, that will make a diagnosis of the cancer. Without going through all the way that we would assess these patients, I think that in short, it's fair to say that the mainstay of treatment in this country at the moment is surgery. There are some very early pre-cancers that can be treated with some cream that you can put onto the penis, but that's the minority. In the majority, you either need to remove the foreskin, if that's where the cancer is, or the head of the penis, or part of the penis, or even all of the penis. Because the cancer can spread to glands in the groin, the patient may need further surgery to remove the glands in the groin. The role of radiotherapy and of chemotherapy is much more limited at the moment. Chemotherapy is not known to be particularly effective, and there's very little data to show that it is helpful. Hopefully trials will be ongoing now that we have these centralised units in the UK to try and see if there are regimes of chemotherapy that can be beneficial. Similarly with radiotherapy, radiotherapy was quite commonly used in the 90s for the treatment of small penile cancers, but it does appear to be slightly less good than surgery, and is largely reserved now for men who are unable to undergo surgery because they're unfit to do so. Fundamentally, this is a sort of diagrammatic picture of the penis, with a little lump showing the various different types and locations of the tumour. You either remove the head of the penis, if that's where the cancer is confined, and that would be called a glandsectomy, or you remove part of the penis, and that's variable, and the aim is to remove the cancer and a little bit more. And there is some debate about how little that little bit more can be. Or you have to remove the whole of the penis. Now actually the surgeon who did this wasn't me, he's in the room, but this is a chap who's had the head of his penis removed. And by careful plastic surgery and use of a skin graft onto the remainder of the penis, you can see you can get quite a good physical appearance. It's really not too bad. For a man standing in a gent's loo, the man next to him probably wouldn't know the difference, other than the fact that there has been some loss of length. When you remove the head of the penis, you lose inevitably a centimetre or two. And also inevitably, you have some change in sensation. The skin on the head of the penis is really very sensitive, and the skin graft really never reproduces that completely. On the other hand, this is a man who had a big cancer and had to have his whole penis removed. You can see that what you've had to do there is pull the scrotum forward to fill the defect where the penis had been removed, and he is now peeing through a little hole just behind the scrotum. That means he has to sit down to pee. And he can pee, there's not a problem with that, he'll have continence, he won't be wetting himself at all. But it's quite different for him. And these are the functional consequences that aren't particularly well researched, and which are important to talk to all our patients as they undergo and as they go through treatment. And indeed, it was one of the main motivators why we pursued this project, to provide better patient information for patients as they go through their treatment. Not all men die from penile cancer. Although the surgery, as you can see, can be quite mutilating on occasions, the majority of men actually are cured. We would expect 85% of men to still be alive 1 year after diagnosis, and 70% are still alive at 5 years. And that comes from UK-wide data. It hasn't changed very much, interestingly, over the past 10 years or so. But we'd be hoping to see the advantages of the centralisation of services begin to become apparent about now as years go by. The data that we've got currently is up to about 2009-2010. And finally, the functional outcomes. As I've already said on a number of occasions, this is poorly documented. It's poorly documented, but although we do think that the more radical the surgery you have, as you might, this would appear to be fairly obvious, the more radical the surgery, the greater the consequences. But in terms of sexual function, there is reduced erectile function because you lose the sensation. Without the sensation, it's more difficult to get an erection. The erectile tissue is still there. So actually it is still possible to get an erection, but it's more difficult to have satisfying intercourse, and we know that. Voiding function is quite different. Without the leg, it may be that the men have to sit down to pee. There's almost always a degree of spraying, rather than that perfect stream that all men have early in their life. There may be some spraying of that. And that may mean that the man has to sit down rather than to stand up to pee. And finally, if there's loss of length, even if he's got a penile stump, there may be very little there to hold on to, and that may be troublesome for the patient. Then there's psychological outcome, and I think that is probably the thing that's researched least of all, the effect upon masculinity, over and above the effect of having cancer. It's one thing having cancer and having the effect of that, but having cancer of the penis is an additional psychological consequence. And those things were really the motivation to try and get men to talk about how they got it that precipitated this study. Thank you very much.